The title of my talk is Can We Do Better? And I am a section head at the Department of Neuroradiology at Karolinska University Hospital. I'm also the medical director of diagnostics, and I'm an associate professor at Karolinska Institutet. I have some disclosures. I hold patents and stuff for catheters and some for processing tomographic data, but I have no financial interests in CERCAR at all. And Karolinska University Hospital has an innovation partnership with CERCAR through public procurement. So that's the relationship that we have, which is fairly important. I also really want to thank the organizers of this event. I'm so happy to be here, and I'm so happy to be allowed to talk, and I'm really looking forward. I think it's a super exciting program with lots of interesting stuff going on, and it will be great. But I'm gonna rain a little bit on the parade now. So we have this thing called evidence-based medicine. The conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. Are we doing that? And what is the level of evidence that we're generating in MRI in general and in MRI perfusion? Is the level of evidence that we're generating good or bad? That's something I want all of us to think about. So you can divide all these into different levels of evidence. This is the Canadian task force. You can have 1 in a Roman numeral, and then you can have 2.1 and 2.2 and 3 going down to basically it's from randomized clinical trials. You can have the SACET, large randomized clinical trials, going down to case series and studies with no controls. You can have this, the Center for Evidence-Based Medicine 1A, systematic review, several randomized clinical trials, multi-center trials with homogeneity, and then doing systematic reviews of that. So basically I do all of this with MRI, but my main clinical work since the last couple of years has been in interventional neuroradiology. So the stroke thing, that's level 1A. I went to Istanbul in 2014 at the Symposium Neuroradiologicum, which happens every 4th year. And the Americans were like, you guys in Europe, you're killing your patients. Why are you doing thrombectomy? You're killing your patients. That was what the US people were telling us. And we were like, probably not. I mean, they come in and they walk out. So that's probably a good thing. And they were like, you're killing your patients. You do not know. And from that session in 2014, it was, I mean, they were correct in a sense. They were correct in a sense. And then 2015, you get all these really large RCTs, you get the Hermes, the collaboration, you get the systematic reviews, and we're off. So that's where thrombectomy is. Where is perfusion in this? We have case series. A lot of stuff, because there's a lot of moving parts in this. A lot of this is even down to expert opinion. Or maybe just popular opinion, or your own opinion. So let's look at a systematic review. There are some, if you look hard. So this is from oncology, neuro-oncology in 2017. It's quite old now, because we're not doing these in this field. Let's look at the studies. This is the quality of the evidence. Not a single study included in the systematic review had a green color all over. And specifically, if you look at the first column, were they prospective in nature? No, they were not. They were retrospective in nature. to a vast majority. And the sensitivity and specificity, is this homogeneity? No, it's not. And they're actually measuring different stuff. It's like max RCBV, it's mean RCBV, it's histogram analysis. They did a sensitivity and specificity analysis looking at different parameters in a systematic review without homogeneity. So, and then there's another thing that we sort of have to ask ourselves as a community. What sort of studies should we be doing if we want to increase the evidence or the level of evidence? Should we do efficacy studies or effectiveness studies? And in Sweden, we don't have a really good word for efficacy, but there is a clear difference in English between, it's the same with random. We have random, but in Sweden, random and haphazardly, it means the same thing. And I think it's the same in Danish. Yeah. And we don't have a good word in Swedish for efficacy. We have effektivitet, which efficacy is something else. So if you try to sort of divvy them up, if you have a question, does the intervention work under ideal circumstances? Then you're looking at efficacy. But does the intervention work in real world practice? Then you're looking for effectiveness. And the setting, is it a resource-intensive ideal setting that you're trying to understand something within a trial, a framework of a trial? Or is it a real-world, everyday clinical setting? Is the study population, is it highly selected, homogeneous, several exclusion criteria? Or is it a heterogeneous population with few to no exclusion criteria? Are the providers, are they highly experienced and trained? Or it's the usual suspects trying to do their best? So where are we at with perfusion? We're rolling it out now. Sercare is taking a huge part in rolling out perfusion from tertiary centers to secondary centers. So we're moving out into a real world setting where we have really low levels of evidence, primarily in efficacy trials. That's what we have, if we want to be honest with ourselves. So, and the intervention is strictly enforced, standardized. So this is an effectiveness example. So Karolinska University Hospitals, we run Sercare, and I've just decided to release all of these in the free with all the microcirculatory maps. It's been an uphill battle, convincing my reading room that this is good. But it's cheap. We do it anyway. It doesn't cost scanner time. We get the automatic maps. And I've been sort of having internal discussions and lecture series over many, many hours talking about this, and they've sort of come to accept it. But this is what happens if you want to look at effectiveness. So this patient, she had breast cancer with metastasis, got cured, got chemotherapy, got stereotactic radiosurgery. Then she had lymphoma, got cured from that. Then the brain metastasis came back, and we hit her with LINAC. You see, that patient doesn't really fit into an efficacy trial, right? And we found this. So apparently Sercare is not great if you've given both stereotactic gamma radiosurgery and LINAC, because the leakage was too much, and Sercare doesn't correct enough with the leakage correction. So you get an elevated RCBV, we don't get it in ISP. And here's the leakage. It's enormous. It's enormous leakage. But this is what happens if you don't do if you only have retrospective data. This is what happens when you release something in the wild. But fear not, we're trying to solve this. We're working on a new new stuff to handle this. But this is what happens if you release something to the wild. And we're now doing that to gather expert opinion. That's what we're doing at Karolinska. Getting expert opinion in my reading room. How does this look like? We have evidence. We're going to hear about evidence now. But what about 3 years after stopping radiation? What are we seeing in the microcirculatory changes 3 years after stopping? Is that induced by radiation? Or is it something else? Is it a biological? We don't know. We don't know. We have no evidence. But we're trying now to form at least an expert opinion. We can look at the parameters. This is a consensus recommendation, also in neuro-oncology. Does the parameters matter? You can probably arrange an entire week discussing the parameters. But if this is a consensus recommendation, what sort of level of evidence are we at, again? So, what we need to ask ourselves are a few questions going forward. Is the signal from the underlying pathological process strong enough that it doesn't really matter? We can have a wide range of parameters. Then we can do effectiveness trials. If we cannot agree in a consensus recommendation, where a lot of people that I thoroughly respect were co-authors, if we cannot agree on echo times, then we need to do efficacy trials, where we scan the patient, we take them back 5 days later, we scan them again, we randomize, we blind it. And then we have to settle. We have to do this. Or the signal is strong enough. We don't care. Let's do an effectiveness trial where we would allow any center to use any parameters that they think are the best. Because the signal is strong enough that the echo time doesn't matter. So, do we have regions of interest selected by neuroradiologists, radiologists, residents, radiologists, some staffer, the janitor, anyhow, and then eyeballing the curves, and it's good enough? Or do we need to do manual segmentation of contrast-enhancing areas and the non-contrast, and then look at that, and then do the histogram analysis? Then we have to do efficacy trials. The study population, should it be anyone? That's what we're doing now to form an expert opinion. Or should it be, we're going to look at WHO grade 4, it's going to be P53 wild type, and it has to have Ki67 between 15 and 18%. Those are the only patients that we care about. Where are we at now? We have to ask us these questions. We have to move forward, but these questions are important. I'm a very practical, clinically oriented man. I want to solve stuff for my patients. I like research. I started out doing ultra-high field MRI, but now I'm in a position where I have to make something work for the patients. The providers, should it be tertiary centers like us, or should it be, I don't know, anyone? So what do we need? So the problem, is the imaging signal strong enough and quantifiable? Because now we're at a point, presumably already towards the fall, and within the framework that Sercar is developing, in collaboration with many of you here and with us, where we can probably do a lot of stuff fully automated. And that means that we can control the environment, and we can do effectiveness trials where we can reduce the parameter space in what we do. So if the signal is strong enough, we can have fully automated calculation of the parametric maps, tolerating a wide range of scanners. Probably. We need to do systematic extraction of data. So we have to quantify. But we can probably very soon do fully automated segmentation of the structural volumes of interest and co-register them to the parametric maps. We can probably do some sort of natural history study over a heterogeneous population. And we need to start to not even only do prospective trials, but we need to pre-register our trials to increase the level of evidence. So, hopefully, when I come here in 5 years, we will have prospective natural history data with pre-registered probabilities for underlying molecular profiles that are calculated through a fully automated segmentation and co-registration algorithm informed by both structural imaging and perfusion parametric maps. And then we must withhold this from the patients and not do it to at least half of them. Like we didn't do thrombectomy to half of the patients coming in with hemiplegia. If we don't do that, we will never have high-grade evidence. So we have 39 scanners in our fleet, and our setup is that we run the Sectra packs. The scanners send it to the PACS. The PACS says, the Department of Radiology did a neuro-oncology study. It sends it to virtual servers. It sends it back. We have it in the reading room. It's fully automated. We get all the microcirculatory maps. Super good. I love it. All of this I want to use to do effectiveness trials. I think that we're very soon in a position to do effectiveness trials. And anyone who wants to collaborate with me on that, reach out, because I can't do it alone, even with 39 scanners. We need to form consortia trying to do. There are probably some efficacy trials that we have to do, but then we have to do large-scale, multi-center effectiveness trials. And I would be happy to devote a lot of our resources that I can devote to this. I don't know how I got into that position, but I would be very happy to devote a lot of resources to this. And anyone who wants to do it with me, please contact me. Thank you.